So finally, let's look at the debate over healthcare policy in the United States. Back in 2010, the Patient Protection and Affordable Care Act, the ACA, or otherwise known as Obamacare, was passed by Congress, but it still remains controversial to this day, although it's still largely in place in the law of the land. Despite this massive healthcare reform in 2010, the US still spends more per person on healthcare than any other country without getting better outcomes. And this cost continues to rise over time. So, did the Affordable Care Act fail? Was it even able to address the problems that we see? What can we do about in the future? These are things we're going to explore a little bit more in this section. Now, I'm not going to look too much at the Affordable Care Act. People have talked about that almost to death in the past 11 years now. But there's a lot of other things going on that I think we need to focus on, and that are too frequently left out of the healthcare debate. Okay, so here we have the figure on the right, healthcare spending as a percentage of GDP in the United States. We have it over time from 1965 to 2015. And we can see it's been steadily rising over time, and it's projected to continue to rise, which is that dashed line in there. It started at about 6% in 1965, and now it's up over 15%. And they say one of the problems with healthcare policy in the United States is that healthcare spending is about 1/7 of our GDP, but no one wants to spend 1/7 of their income on healthcare. Here we have healthcare spending per person around the world. And this figure on the right shows it from 1970 to 2012 in a number of countries. And we see that healthcare spending in the US has been faster than the other high-income countries. So again, I'm trying to motivate what's going on here and what the problems are. Now, this figure is not from your textbook. This is from Random Critical Analysis, who does a lot of good writing on healthcare spending. This is the correlation of per capita income and healthcare spending by country. You see, there's a very strong correlation between income and spending on healthcare. Now, going back to how much Americans are spending over time as a proportion of GDP, while this is increasing, Americans are paying a smaller and smaller portion of healthcare costs out of pocket. So more and more of healthcare costs are being covered by insurers. Americans would not likely choose the same level of healthcare expenditure if they had to pay a higher out-of-pocket share. Remember that case of the Medicaid expansion in Oregon, where people spent the same amount of money out of pocket, regardless of how much insurance they had. So if insurance covered more, they would get much more healthcare. If they didn't have insurance, so they had no coverage outside of what they paid, they still spent about the same amount. Combined with rising healthcare costs, this declining share of out-of-pocket healthcare spending is causing problems for government budgets and is going to have a significant impact in the very near future. So why are healthcare costs rising so fast? There's a lot of things that are commonly thrown out that I kind of want to talk about very quickly. The first is paperwork. While paperwork is significant, it's not increasing fast enough to explain the rise in spending. Excessive paperwork and duplicating forms, spending a lot of time filling out the electronic health records can really take away from the quality of care. My aunt's an RN, and she complained to me when she found out I was doing healthcare research about the amount of time that she has to spend every night when she's doing her rounds, how much time she has to spend on that, rather than actually dealing with patients, which is what she likes to do and what, in general, the most helpful for people. But still, this isn't enough to explain the rising in spending. Malpractice lawsuits. These are often thrown out as a big driver in healthcare cost. The Congressional Budget Office, very nonpartisan, says that 1% of healthcare costs or healthcare spending is from malpractice lawsuits. Some economists estimate as much as 7% of healthcare. But again, over time, these aren't increasing fast enough to explain the changes. These are wastes that could be eliminated, but not the driver of this increase in healthcare spending over time. Some say it's uninsured patients. The increase in costs of 1 to 4% due to getting treatment in the wrong places, so going to the emergency room versus the doctor's office. Again, this is still waste. It still makes it more difficult to receive healthcare. I've been in the ER for injuries where I've had to wait a very long time because people were going to the emergency room for treatments that they should be going to a doctor's office for. but they didn't have insurance, so they had to go to the ER. Still, this doesn't explain the massive increase in healthcare spending that we've seen over the past several decades. So the first reason is healthcare cost disease. It's also called Baumol's cost disease after the economists who studied this. Um, so what happens is service providers, like healthcare providers, like education providers, have not seen huge productivity gains like we've seen in manufacturing over time. Labor productivity in healthcare, in fact, has risen by about half as much as in the economy as a whole, despite the large number or the incredible advancements in technology that we've seen in the healthcare industry. It's kind of tricky to explain using theory, so I'll use an example. So back in the 1820s, when Beethoven's any of his music was played, it took 4 people about 40 minutes to produce a performance. You needed 4 different instruments played by 4 different musicians. It took 40 minutes to do it. In 2010, it still takes 4 people 40 minutes to do it. So there's no growth in musicians' labor productivity in this case. They can't do it any faster than in the past. Now, most other sectors of the economy have experienced substantial growth in labor productivity since the 1820s when Beethoven wrote his music. So in let's say 1826, the hourly wage for a production worker was a little over $1 per hour. In 2010, the average hourly wage for a production worker is about $26 an hour. So it's about 23 times higher in real or inflation-adjusted terms. So this has kind of a surprising implication. The output of slow productivity growth sectors are become relatively more expensive. So the opportunity cost of playing some music from Beethoven back in the 1820s had an opportunity cost of about $3 because of the very low wages, just over $1 at the time. At the wage of $26 that average workers have now, the opportunity cost is up in the 70s. So it's now it's 23 times more expensive to produce a performance of one of Beethoven's songs today than it was way back when he wrote it. So this is what we see going on with healthcare, is that we don't have as much productivity increase in healthcare as we've seen in things like manufacturing. And the reason is it's still a very worker-dominated, worker-heavy industry where you need people providing these services to the patients. You can't just, automate everything like we've been able to do in large respects for manufacturing. So you can add a lot more technology and a lot better technology, and we have done that for healthcare. And it has definitely improved healthcare outcomes, and we've seen life expectancy increase substantially since we've been introducing these over the past 100 years or so. But because we still need the same number of workers, we end up with more and more costs, especially as we have higher wages coming in other industries. So besides the cost disease that we're seeing in healthcare, just like other services, another reason is the aging population. As the baby boomers age and this large demographic now moves into their retirement years, we have a lot more people that require much more healthcare. Healthcare usage tends to go up over time in a person's life. As life expectancy increases, again, we're going to have much more old people than we had in the past. So we're going to need more and more healthcare services for these people. As the figure on the right shows, it's estimates from the Congressional Budget Office. The effect of aging shouldn't be overstated. It's not entirely taking up all of the increase in healthcare spending, but it is a pretty decent portion. And the final reason is that there's distorted economic incentives that are caused by health insurance. So patients don't bear the entire cost of the procedures that they're going under, or the healthcare services that they're receiving. So we assume that they're going to purchase too much. So analyzing this with the negative externality, what we end up with is the demand curve for the market is at D2. The demand curve for what would be socially optimal is at D1, so it's actually lower. Without um, without third-party payers, so without insurance companies, the price would be lower, but the quantity of healthcare that is being produced would also and consumed would also be lower. Because people don't bear the full cost, they're willing to purchase more and more healthcare, more than above what's optimal. In 2009, President Obama proposed significant healthcare reforms. That became the Affordable Care Act that was passed in 2010. Um, yeah, it was a huge bill. There's a lot of different requirements in there. That's not something I'm going to test you on or expect you to know, but includes things like the individual mandate where people had to get insurance. They set up state health exchanges to increase access to health insurance. Um, More employers had to were forced to provide health insurance to their like entry-level employees or to any full-time employees. Um, they regulated much more heavily health insurance, so controlled how they could act. They expanded Medicaid eligibility to 133% of the federal poverty line, and they increased taxes on high-income individuals in the so-called Cadillac plans. So what Obamacare did in effect was like subsidize demand. Um, and all sorts of universal coverage do this. Again, because consumers aren't bearing the full cost, they're having a certain amount of it, and in the case of the United States, a large percentage of it, paid for by their insurers or by the government. This is going to increase demand. And remember from way back in Chapter 3, an increase in demand is going to increase the prices and the quantity bought and sold. So it's increasing the amount of healthcare that people are purchasing, which is, on the one level, it's a good thing. People are able to receive more healthcare, but it's also going to be increasing the prices. Now, other policies that focus on increasing the supply of healthcare can help bring down prices while increasing the quantity of healthcare that's being consumed by people. So much of the healthcare debate focuses solely on who's going to pay for healthcare, and it ignores how do we get more healthcare available? How can we actually bring down the prices? Not just the prices that people are paying out of pocket, but how much as a country we're spending on healthcare. So these are a few things I want to touch on the next slides that talk about this. So the first thing I'm going to talk about is occupational licensing. My research area specifically is occupational licensing and a little bit of healthcare scope of practice laws. So obviously I'm going to be talking about licensing in this chapter. Licensing is ubiquitous in the healthcare industry, but it is covers many occupations. Basically what licensing is, it can be thought of as a permission slip from governments for people to be allowed to work in a certain profession. And they set the requirements that you have to meet ahead of time. So they lay out the requirements, you have to meet them, fill out an application, and send it into the board, which then has the decision to approve you or deny you to come into the industry and begin practicing. Now, some of the requirements are paying fees, so application fees, testing fees, things like that. They normally have a set level of education that you have to attain. So they may say you have to have a bachelor's degree, a master's degree, things like that. Again, you have to take exams to demonstrate your quality. You often have to undergo a certain period of training. And there's other things, like they may set minimum ages. You may be required to have proficiency in English. May be required that you have the nebulous good moral character clauses. And these laws are passed at the state level. However, in healthcare, there's been a movement to standardize the requirements for different professions across all 50 states. So they're extremely similar nowadays. There are different types of occupational regulation. Licensing is the most strict, where in order to be legally allowed to work in a field, you must be licensed and you must do these certain things. But there are some other less onerous methods. One is certification, where in order to use the title of whatever your profession, you have to, again, meet certain education requirements, exam requirements, pay fees, and you in generally apply and be accepted by a board. But you can still practice without that. So one example is certified public accountants. You have to, in order to call yourself a certified public accountant, you have to go through the entire process to gain the certification. So you have to have, 150 credits. You have to pass those 4 accounting exams, things like that. But you can also do accountant work without having a CPA, but you can't call yourself a CPA. And one of the weaker forms is registration, where the government, like, you have to send them your information if you're going to be working in a field, but they don't have any sort of education requirements or exams you have to take or anything like that. But if something goes wrong, they have your name and contact information, so they make it much easier for someone to, sue you if you did something wrong. Now, the purpose of licensing is to prevent low-skilled professionals from entering a profession. The stereotypical snake oil salesman going from town to town selling these, fake potions that are supposed to help people, but really they end up hurting them or doing nothing. So you protect consumers from harm. It also reduces the information asymmetry. Remember, we talked about earlier, people not having knowledge that the other party in the transaction has. So as a patient, you generally don't know how good your physician is going to be until after you get treated. Now you can look at reviews online, you can talk to like friends from like word of mouth, but it's still pretty risky to go to a physician that you know nothing about. So licensing is a way to reduce that. If someone's licensed to be a physician, you know that they graduated college, they went to medical school, they've done their residency for so many years, they passed the medical licensing exam. They've done all these things, so you know they're good quality. So it encourages people to, purchase services. So now, what's the effect of occupational licensing? Well, because of these increased costs of entering a profession, it becomes more difficult when you have these barriers to entry that are being set up, whether it's taking the exams, the long training, things like that. It ends up decreasing the supply of professionals within that field. So in the case of healthcare, there are fewer physicians because of the barriers to entry of occupational licensing. There are fewer nurse practitioners, there's fewer registered nurses, fewer licensed practical nurses, all the way down. Now, what this does is limit competition, and this raises professionals' wages. Now, because we've now decreased the supply from what there would be if there was free entry into the profession, now these barriers to entry shift the supply curve to the left, which we see on the figure on this slide. It increases the price from P to P dash, and it decreases the quantity of services being provided from Q star to Q dash. So in professions or in industries where we have occupational licensing, we would expect higher prices for consumers, and we'd expect fewer professionals in those industries and fewer services being offered. And time again, that's what research finds. A lot of my research, a lot of Ed Timmons, who's he's been the economics professor here for about 10 years, and he's published extensively on this, estimating the effect of occupational licensing on many specific professions. And again, that's what we consistently find. Now, that's not to say that there is no possible positive effect. If there is increase in consumer confidence, if there's an increase in the absolute increase in quality of healthcare that's being provided, that should increase the demand some. So here we have on the figure the demand curve shifting out from D to D dash. So the price, again, is going to increase a little bit because we now have a little bit more than it did on the previous slide, because we have more people willing to buy, to have these healthcare services. And we also have a slight increase in the quantity being provided. So like the other things, occupational licensing is not the number one thing that is, driving healthcare costs or reducing the access to healthcare. And also, it's not to say that there's no improvement in quality due to licensing standards and making sure that people that are entering these professions are well trained, even though it's very difficult to find research that shows an effect, a positive effect on quality, which is kind of surprising and counterintuitive. The Obama White House had a good policy paper they put out analyzing all the effects of occupational licensing and looking at all the literature that had been published at the time. This was back in like 2015, and they found no effect on quality, or no discernible effect on quality. But this is very important, reducing the supply of healthcare providers. And there's things that we do that we could slightly, we could tweak or we could reform a little bit about licensing laws in different states to make it easier for people to enter these professions. We currently have a shortage of physicians. We've had a shortage of physicians for about 10 years now in this country, across the entire nation. And in different areas, we've had shortages for much longer. We're also now just entering a shortage of nursing, despite the fact that nursing has been growing, like healthcare in general, as a profession substantially, so leaps and bounds over the past 2 decades or so. We're still now entering a shortage. Some states have had nursing shortages for many years now. So policymakers are trying to figure out ways to allow more people to enter professions. There's some little things like we currently don't allow people to use their relevant military training to enter healthcare professions. So trying somehow to use or to incorporate military training into accepting or to meeting licensing standards. So how much does it cost to get healthcare services? This is another problem that we see, that we very rarely, if ever, know the prices. And they're not advertised to people. People don't know how much they're paying for the healthcare procedures they're receiving. Now, in a well-functioning market, the competitive forces will help keep prices similar. So you're unable to, profit by purchasing something cheaper somewhere else and then reselling it in a different market. Consumers are able to shop around, so they'll find the lowest price areas. They'll get overrun with demand, and this will slowly increase the prices, bringing up in line with the other providers, who, because they have less demand, will probably be lowering their prices as well. Now, this table on the right shows the variance in prices within cities for MRIs. So, like in Houston, the highest price in the city for an MRI is $4,800. The lowest price is $675. Because there's no advertising prices, there's no menu where you walk in and can see the cost of these different services, there ends up being a huge difference in prices. There's no price competition. And again, because third parties are paying for healthcare, so people are putting a very small percentage of that healthcare coming out of their pocket, people aren't very sensitive to those prices anyway. I'm recording this lecture in February 2021. We've been dealing with the coronavirus, or COVID, for a year now, just about. Through most of this time, there's been people freaking out about hospitals and healthcare providers being overrun with patients. Yet, as of today, the day I'm recording this, in Iowa, they denied the request for the expansion of one of the hospital, adding a bunch of new beds into one of their wings, because their competitors feared that it would put too much pressure on them. This is not a joke. The reason why this is possible is because of what's called Certificate of Need laws. Certificate of Need laws basically set up a board in a state, and if you're a hospital or if you want to open a hospital, you have to go before this board and ask them for permission. And you have to demonstrate that there is an unmet need in your area, in this area, that no other healthcare provider is currently meeting. Now, this is if you want to add more beds to your hospital, so expand the size of your hospital. If you want to offer a new service, so if a hospital wants to begin offering MRIs or CT scans, if they want to begin offering like mental health services, things like that, or if they want to purchase certain pieces of equipment. Now, back in 1974, Congress began requiring, or not began requiring, they required states to enact these Certificate of Need laws. The goal was to lower healthcare costs by not allowing healthcare services to increase. This should sound weird to you, having taken this class and looking at supply and demand, but this is what Congress thought at the time. There was the idea that unregulated market competition would drive medical providers to overinvest in facilities and equipment and end up raising the cost of medical care. Again, laughable that increasing the supply could somehow increase prices. It became evident after a while that it wasn't working. So in 1987, the federal government repealed the Certificate of Need law mandate. And slowly states began retiring their Certificate of Need programs, but many states left the laws on the book. And in 2015, 36 states still had Certificate of Need laws in place. You can see that on the map down there on the bottom right corner. All the gray ones are states that removed their certificate of need laws by 2015. Now, states with certificate of need laws, there was some research done by Thomas Stratman and Jacob Russ from George Mason, the Mercatus Center, where I worked when I was in grad school. I actually helped out on some of these projects. States with common laws had 131 fewer beds per 100,000 people. So if you live in a state that had a certificate of need law, like on the books, there were fewer hospital beds available. Remember in COVID, we're worried about overwhelming the ICU wards? Well, states with certificate of need laws were at more risk. They had fewer beds than states without certificate of need laws, which we would expect when you're going before and arguing against your competitors to allow you to expand the services you're offering. They also found that 37% fewer hospitals offered CT scans in states with certificate of need laws versus states that didn't have certificate of need laws. So health economics is complex and could be an entire course in and of itself. This is just a brief survey of some of the issues and some of the potential solutions and room for reform in the American healthcare system. With healthcare expenditures consuming nearly 20% of national income today and steadily increasing, finding a way to control costs is very important. Things like almost cost disease are difficult or impossible to overcome. Third-party payment is very difficult to overcome, but it can be altered in some ways to at least mitigate the issues, even though it would be next to impossible to get rid of it completely while still having third-party payment. But there are other things, restrictions on supply that we have, that have very simple solutions, and these reforms are very possible to enact. And hopefully this gave you just a brief overview and intro into some of the concerns, some of the different topics that we cover in an entire health economics course.